So next up we have Dr. Vendana. She is a assistant professor here at the UT Health, I'm gonna get this right, the Pediatric Neuroscience, UT Health Austin Pediatric Neurosciences at Dell Children's Medical Center, and a assistant professor at the Department of Neurology at Dell Medical School. She received her bachelor's from Millsaps College, where she graduated top of her class. She also trained at the University of Mississippi Medical Center, where she got her pediatric neurology residency training. Initially started in anesthesia, which is a fun fact that I learned by looking her up for this. But before she saw the light and came over to pediatrics, so we're really glad that she did. She's a wonderful child neurologist, and she's going to give a great talk on ADHD that I'm very excited to listen to. Thank you.
Thank you. Thank you so much for that lovely introduction, and thank you everyone for inviting me to come by and talk a little bit about ADHD. The title of my talk is The ABCs of ADHD, and I'm happy in the next few minutes to take you through this disorder very briefly. I have no disclosures that are relevant. Well, now more than ever, in the last few decades, we all feel as though we're living in the age of ADHD. We know that ADHD is the most common neurodevelopmental condition found in pediatrics, and the CDC estimates that up to 10% of the pediatric population has had a diagnosis of ADHD at some point in their life, which is a substantial amount. Most recent data that we have out of the CDC suggests that about 6 million pediatric patients have had a diagnosis of ADHD, and that's not even taking into account post-pandemic numbers. Before, though, we talk about the present, I wanted to take a step back in time and talk about the history of the disorder. In 1798, the Scottish physician Alexander Crichton wrote about the disorder in one of his medical textbooks on attention and its diseases. I'd like to read a quote from that. It's a little bit of a longer quote, but I think it's interesting. He wrote, "The incapacity of attending with a necessary degree of constancy to any one object almost always arises from a morbid sensibility of the nerves. This faculty is incessantly withdrawn from one impression to another. It may be either born with the person, or it may be the effect of accidental diseases. When born with the person, it becomes evident at a very early period of life and has a very bad effect. It renders him incapable of attending to any object of education. But it is seldom in so great a degree, and what is very fortunate, it is generally diminished by age." So even back then, in the late 18th century, we see a lot of the hallmarks of the condition. It presents early in life. We know that it can cause educational struggles that can be severe in nature. And we know that it can be due or related to secondary causes or be associated with comorbidities. We also know that it can improve with time. Hyperactivity, as we know, is the symptom that most often improves. Moving on, though, in our timeline, let's go to 1937, where the physician Charles Bradley in Rhode Island worked at a children's home for children with neurologic diseases. At that time, they would evaluate their patients by using something called a pneumoencephalogram, which involved draining CSF and replacing all of that with air or oxygen. They would subsequently take an X-ray. As you can imagine, this resulted in some very fierce post-dural puncture headaches. In the interest of curing that, Bradley hypothesized that giving the stimulant, Benzedrine, would stimulate the production of CSF and tried it on his patients to reduce their headaches. This did not work. However, he did notice, again, since this was children's home, they would get their schooling through the hospital itself. He did notice that it had a spectacular effect on academic performance. So in failing to treat a headache, Bradley was the first to discover the positive effect of stimulants on ADHD. In 1944, almost 7 years later, the chemist Leandro Pennison synthesized methylphenidate, which is one of the most commonly used substances we use for treatment even now. As one did in those times, he took some of his newly synthesized compound home and tested it on his wife. Apparently, it gave her a kick in her tennis performance. Her name was Rita, so when it went on sale, it was called Ritalin in her honor. And I think we will say the poor woman probably deserved it. In 1980, attention deficit disorder, as it was called then, first was entered in the DSM. As we know, that's when you've really made it as a diagnosis. It was first called attention deficit disorder with and without hyperactivity. Then when it was revised, it was called attention deficit hyperactivity disorder. As we know, there's been a lot of back and forth. In 1994 is when they finally decided on calling it attention deficit hyperactivity disorder, which is how we mostly know it. But again, there is a lot of confusion even with parents as to what it's called. In 2002, the compound atomoxetine was approved for medical use. It's sold under the brand name Strattera. It was first developed as an antidepressant, was found not to be efficacious for that purpose, but was very helpful in helping symptoms of inattention. And that is why this came on. We'll touch base about this medication a little bit more in a bit. And finally, in 2009 was when guanfacine XR was approved for the treatment of ADHD. It was only in 2010, the year following, that clonidine XR was approved. While these medications are also ones that we'll talk about a little bit more in a few slides, you can see that we have had like a slow progress in medications up until the most recent years when it really seems to have ballooned. But moving on, though, leaving history behind and moving on to what we presently see, let's talk a little bit about how we identify and diagnose patients. When we think of patients that present to clinic, first point I always like to make is they don't need to be 6 years old. That's a common myth that we hear a lot. We usually wait until patients are about 4, as behaviors will often stabilize and become more noticeable compared to an age-appropriate behavior. However, according to the CDC, almost 2% of the total children diagnosed with ADHD in its most recent survey were between the ages of 3 and 5. So again, there is a substantial amount of patients who are being diagnosed younger than age 6. We know that boys are more likely than girls to be diagnosed. This doesn't necessarily mean that they are more likely to have the disorder, mainly that as they more likely present with hyperactive behaviors and symptoms, their behaviors are more likely to come to attention of teachers and parents. Finally, in Mississippi, where I trained, and Louisiana are the states with the highest prevalence, greater than 15% in the most recent survey, of ADHD. Texas has a still fairly respectable 10% of ADHD, which, like we talked about, is very much in keeping with the most recent national data that we have. Moving on to the DSM-5 criteria. I know this is a chunk of text. I will let you guys read at your own leisure. We know that there are inattentive and hyperactive symptoms. I'll move on in a few minutes to the hyperactive symptoms as well. But what I would really like to draw attention to is remembering that for children up to 16 years, you need 6 or more symptoms to be documented. If they are 17 and above, including adults, you only need 5 or more symptoms. These symptoms have to be present for at least 6 months, and they need to be inappropriate for a developmental level. Particularly with that last point, I like to say when we are taking a history, it's important to ask, especially for our younger children, that we're asking this on an age-appropriate level. For example, when we ask, do they avoid tasks that require mental effort over a long period of time? Most 6-year-olds are not being assigned homework that involves that much effort. What I like to ask instead are they having a hard time doing puzzles at home? Are they reluctant to do, say, an activity that they know is going to take a long time? Do they dislike doing reading practice because they know they have to sound out the letters little by little? What exactly is giving them more difficulty? Same thing too with hyperactivity. When we notice that parents say their children have a hard time staying still during church. Well, if any of y'all have, a 3 or 5-year-old that can stay still for 2 hours of mass, well, congratulations, good for you. Again, the things that we look for more, especially with younger ages, is, are they having a hard time sitting still through a family dinner? Are families saying that, they're having a hard time controlling their kids because of impulsive behavior that could be dangerous? So always remember when we ask for these symptoms to make sure that they're on an age-appropriate level. And when we ask parents to kind of reply on surveys, that you're counseling parents to fill that out appropriately. Finally, even after we do these, after we look at these symptoms, we want to meet the following conditions. They need to be present before age 12 years. We can make the diagnosis of ADHD if the patient is older than 12 years, even into adulthood, but they have to demonstrate, whether that's through family stories, records of parents, that they had these symptoms even before age 12. You want to make sure that they have several symptoms that are present in 2 or more settings. At home, school, work, therapy sessions. Again, another question people have, especially for younger patients, is what if they're homeschooled? What if they don't, what if they're not going to school yet? What if they're not going to daycare? One of the things that we can recommend is if they're in therapies, if they go to, say, grandma's house, if they go for a Mother's Day out session, those count. You can certainly ask guardians at that time to help provide information as well. In addition, if mom is just not quite sure, sometimes I'll recommend maybe doing a trial of daycare, just long enough that we have a look at how this patient does in another setting other than home. And then we also want to see, when we're making the diagnosis, that this does interfere with the quality of life or functioning. We all feel bored. We all feel hyperactive. We all feel fidgety. But we are usually all able to overcome that. With these children, we want to see proof that this is causing them some amount, even if that, a lot of these kids can have good school performance. I wouldn't go solely based on school performance, but is this causing them difficulty, distress in some other way? We do want to document that. We want to be sure that we are aware of that. And again, this is usually the case with the DSM. Finally, you want to make sure that these symptoms are not better explained by another disorder. Multiple rating scales are available for us to screen or to monitor these symptoms. I've listed them, but I feel like the one that we are most familiar with and that we use the most often are our trusty Vanderbilts. One of the wonderful thing about Vanderbilts is that they include many of the DSM criteria that I went over just recently. The first 9 questions of the Vanderbilt are in line with the inattentive symptoms that we see for ADHD. The next 9 are in line with the hyperactive symptoms that we see. It also provides screening for conduct disorder, oppositional defiant disorder, and anxiety depression that we want to be aware of, as well as the extent to which this affects people in their life. So by getting parents to fill this out, you've really completed a pretty thorough look at DSM-5 criteria, which is why I really recommend having this done. But we'll talk more about that in a bit as well. I'd like to kind of take some time to talk about comorbidities and the differential to keep in mind. Firstly, for children with ADHD, that does not prevent them from having any other disorder. The most common comorbid disorder, as you can see, is a behavioral conduct problem in almost 50% of patients. Anxiety, depression are very frequent as well, as are autism and Tourette syndrome. So common coexisting disorders I like to always counsel to keep in mind are learning and language disorders. Again, while some say that, well, is it the learning or language disorder or cognitive concerns that keep them from showing this, it is certainly possible for them to have both. What we want to make sure is that they're not having a double hit. We really want them to treat the symptoms of their ADHD to help them overcome their the difficulties caused by any potential underlying learning or language disorder. Autism, as we talked about before, sleep disorders, depression, anxiety, oppositional defiant disorder, all of those can also be associated, as can be substance abuse. So those are all things to screen for in patients, even if they do have a diagnosis of ADHD. When we look at the differential, we want to look at normal developmental variations, such as giftedness or cognitive or impairment, metabolic disorders, neurodevelopmental disorders, such as Fragile X, fetal alcohol syndrome, Klinefelter. Are there any psychosocial stressors that are instead causing this, particularly if you get a history that this is not present in multiple environments, but rather only in one? Any hearing or visual impairments, concerns for lead poisoning, sleep disorders, most classically obstructive sleep apnea, any thyroid abnormalities, medication effects, or any concerns for inattentive spells, staring spells that are mistaken as ADHD, but maybe a presentation of absence epilepsy. In clinic, if you obtain a history or physical that suggests any of the following, it is reasonable to go ahead and obtain an audiology evaluation, speech evaluation, OT or mental health evaluation. In terms of lab work, consider a lead level, thyroid level, potentially genetic testing if any dysmorphisms are present, potentially refer patients to a sleep study, or for neuro exam. In terms of, moving on though to, let's say you don't find any of those, it is reasonable to start treatment. For those patients who are younger than 6 years, we know that the recommended treatment as per the AAP is behavioral therapy, specifically parent-based behavioral therapy. We recommend this because children younger than 6 years will often have more side effects that are noted. For patients that are older than 6 years, we usually recommend both behavioral therapy and medication management. Briefly talking about the categories of medications, you have your stimulants, methylphenidate, and the amphetamines. In the interest of time, I'll lump them together, but we're happy to discuss those further, the differences between those further in the questions. The pros with the stimulants is that they are very effective. They work in about 70 to 80% of patients. They usually have a rapid absorption, rapid onset, and most parents find that they are most familiar with these medications. Cons that you see with those is they are a controlled substance. It can be difficult to get refills easily. They can decrease appetite and sleep, and rarely can cause anxiety, agitations, headaches, and tics. Remember to monitor weight, height, and take a careful history of any family or personal history of cardiac diseases. At present, it's not recommended to get an EKG before you start an asymptomatic patient on stimulants. However, if you do have a patient with any risk factors or any personal history of cardiac conditions, it is reasonable to get cardiology to clear them for stimulant use. Moving on to our non-stimulant options, alpha-2 agonists are also a wonderful option. They're effective in about 60% of patients, and they're also useful, especially as an adjunct medication in those patients who need that. You do see that it takes a minimum of about 2 weeks to really see their effectiveness, and they need to be regularly taken. Unlike patients who are on stimulants, you cannot often prescribe like a medication or weekend holiday for these patients. They most commonly will cause sleepiness. You can also see a drop in blood pressure due to the nature of the medication, loss of appetite, dizziness with those. Similarly, the non-stimulants, Strattera and Quilbry, are the brand names for those. The generics are provided. They are our selective norepinephrine reuptake inhibitors. They are also very effective. They're effective in about 50% of patients, so maybe a little bit less, but still pretty good bang for their buck, I'd say. Most commonly, they can cause moodiness or drowsiness, so that's a good thing to counsel families about before you start. Rarely, they can cause liver function derangement, so it is reasonable to get a baseline liver function test, especially if there are any risk factors. Again, much like the alpha agonists, these can take about 2 to 4 weeks to really build up in the system and for you to see their full effects. So that is another thing to counsel parents about, that you're not going to see that instant wonderful effect that you might with your stimulants. Recommendations for parents, even besides starting a medication, parents often really want advice on how can you parent? What should we do? So these are some of the recommendations I like to give. It's really best to create a routine for these kids. We know most kids thrive on routine, but all the more knowing what to expect makes life easier for them. Limit choices. Narrow it down to about 2 or 3 options, and it's much easier to pick one between them. Manage distractions. If we're working on schoolwork, if we're working on any other kind of task that may take a long time, try to make sure that they're not surrounded by electronics, loud family, whatever it takes to keep these kids focused on what they need to be doing. Try to break complicated tasks into manageable smaller steps. For older kids especially, checklists that they can do either on paper or on their phones are a really good option to discuss. We know that praise and positive opportunities are just better for parenting than negative criticism, so as expected. And as always, a healthy lifestyle with exercise, nutrition, and sufficient sleep is always best. Fine. Now, despite all of those, there are times where we all need extra help. We are always happy to see these young patients, but these are times in particular that I feel that a neurology consult would be very much indicated. If your first-line therapy fails, if there is concern for autism versus ADHD, as Dr. Brumback will be talking about in a few minutes, many of these two conditions can often overlap and mimic each other. So we're certainly happy to help clear up some of that confusion. If there is any concern for comorbid tic disorder, underlying neurodevelopmental syndromes, or other neuro concerns that you notice, or bad headaches that are going on, or as we talked about, concern that some periods of inattention may instead be absence seizures. Before they come to see us, we would find it very helpful if we could get Vanderbilt forms, parent and teacher filled out, and just counseling mom to bring them. To help to make it such that we can kind of really focus on doing a neuro exam and really counseling parents about therapies instead. In addition, a full school evaluation and psychoeducational testing, if that has been done, is also really great resource for us to look through. And if you see any other comorbidities that may be going on, for example, concerns with mental health, concerns with sleep, it's very helpful to have those referrals already sent in cooking so that we can make sure that we get these kids situated with those. While they're being followed with us, really very helpful to do weight checks. Many of our patients travel to see us, and we often perform virtual visits to accommodate them. But to make sure that their blood pressure, their height, their weight are doing well, it is very helpful if we can get pediatricians to help us out with those. In addition, kind of encouraging family to reach out to us with any concerns or changes that they see with therapies. Frequently asked questions that we get: what are risk factors for ADHD? A family history of ADHD, we know that in twin studies, there's a concordance of about 60 to 70%, so fair chance that there is an underlying genetic cause that we probably just haven't realized yet. Previous history of brain trauma, prenatal exposure to illicit substances, premature birth, and low birth weight have all been identified as risk factors. What hasn't, though most parents will identify this as excessive sugar intake or excessive screen time, there's no actual documentation in the literature that these are risk factors or causative. However, we know that no matter what, excessive sugar, excessive screen time are just not good for kids anyway, and can worsen the symptoms of ADHD, so just best to avoid them. Can stimulants be used in patients with a history of seizures? We often hear, and we do know, that stimulants can lower the seizure threshold in children with this known seizure disorder. However, at this time, we do not routinely contradict the use of this in this population. It is fair to keep an eye on these patients, however, and certainly if you do notice any changes, certainly, let us know. What accommodations or adjustments may children with ADHD qualify for? Parents should request a school evaluation from their school, particularly if they're in a public school ISD. Following these results, they will qualify for an IEP or 504 plan. Our social workers are very great about getting us a really good walkthrough of how to do this. I'm certainly happy to share this through email if anyone has any, would like to see that as well. Finally, I'd like to conclude by talking about some great resources that we have both online to share with both parents and providers. The Children and Adults with Attention Deficit Hyperactivity Disorder, or CHADD.org website, is a great resource to give parents. In addition, the American Academy of Pediatrics has a wonderful toolkit that really walks you through a great algorithm for treatment, as does the American Academy of Child and Adolescent Psychiatry. Finally, VELA is a great resource that we have here in the Austin area. Really helps kids with a number of diagnoses, but one among them is ADHD. So that is a really great website to refer parents to. And that is all that I have. I'm happy to take any questions if there are any. Yes. Thank you.
Only two questions, Vandana. It was a great talk.
Uh-huh.
As general pediatricians, we believe that the smarter the mother, the longer time it takes to diagnose ADHD. So the 12-year cutoff, I mean, in general pediatrics, we see, I wouldn't say kids, those who've done their PhD get diagnosed the first time because the mother's been compensating for them the entire time. And my second question was, I'm so glad you addressed that stimulants will decrease the seizure threshold. If you could just comment, I thought any neuroactive medicine could decrease the seizure threshold.
So I'll start with the first question. So definitely, we can, like with the 12-year cutoff, not a cutoff for making the diagnosis, but it's a cutoff for noticing symptoms. For example, mom will often say, oh yeah, they do this, but even if she's compensating, that is a sign that they've been showing signs prior to that age 12 cutoff. So really, we often do make the diagnosis of ADHD into adulthood. But again, what we would want to see is that mom does say, oh yes, they're always distracted, or, I just have to keep on reminding them, just even if mom is compensating, and that, we would want to hear something that is different about these kids even before the age of 12. Just not something that mom says, well, you know what, they were completely 100% fine until they hit age 17, and then everything just changed like that. That would certainly be something that didn't fit in with that story.
Thank you.
And as for so the second question, to clarify, by any other neuroactive, would that be other medications that we use for the treatment of ADHD, or just anything that works on the brain at all?
Now, this is something that just I thought. I mean, I know stimulants will decrease the seizure threshold, but I thought any medicine that works on the brain will also decrease the seizure threshold.
Not necessarily. Again, it is always best, like I said, still want to take a good medication history on these kids, but there are multiple medications that are not described, that do work on the central nervous system, that are not described as having any sort of link to a decreased seizure threshold. So, no, thank you.
Thank you very much.
Of course, thank you. Oh, yes, of course.
A few years back, I read that the #1 illegally traded and used drug on selective college campuses were stimulants. So, obviously not everyone at Princeton has ADHD, but why is that? Is it enhanced brain function? Why are these kids using it?
No, great question. And it ties into one of the points that ended up getting cut per time. Again, when we take stimulants, particularly, they help us all focus more, right? They are, to use the colloquialism, they are uppers. They're great, right? However, a lot of parents too will say, oh no, I'm so worried that my child's going to get addicted to them. At the doses that we prescribe stimulants, they are not habit forming. They are not going to cause long-term addiction. We do know, however, that children with ADHD are at higher risk of substance use. Again, no link that I could find in the literature to whether or not that they had been medicated or not. But again, the nature of ADHD itself potentially may be linked to, and part of that might be some kids who were never diagnosed, or some adults who were never diagnosed, may be using that as a compensatory measure. Another great question you bring up is exactly the potential for abuse. We do know that using an extended release formulation rather than an immediate release formulation is a better idea, as it doesn't give you that immediate surge of, oh wow, I really feel the results coming on now. I feel great. I can do whatever I want. Extended release formulations are also much less likely to be used recreationally. So when we are starting a child on prescriptions, it is reasonable to go ahead and give them a trial on immediate release, but then long-term really want to switch them over to an extended release as soon as possible. Great question, thank you.
We have a couple questions from the chat.
Okay.
What are the
Oh my, five is certainly a lot. Well, first thing that I will like to say, I don't know if I'm going to hit all. First thing I like to do is I like to make sure that this is a joint decision between myself, the parent, and the child themselves. I like to go through and always talk about the risks and benefits of all of the major categories of medication that we have. Again, there are many parents who, despite kind of talking about the benefits of stimulants, they are often very resistant to stimulants, and I think it's important to respect their wishes, and take that into consideration. But assuming that, the parents, the child, don't have any strong opinions one way or another, I think another thing that is important to is to look into the child themselves. For example, are they the type of child that has, problems with their weight, problems with their sleep already? Are they at risk, like we said, for any of the side effects of stimulants? In that case, like I said, after having a talk with parents, it may be reasonable to trial another medication instead. Other things I like to take into consideration, potentially not with our first choice, but after not my first choice, but not the category, but once we talk about which would be the best fit, how old is the child? What are they able to take? Do we have easily available medications that they're able to take? Are they refusing to take, say, a capsule? Is a capsule too big for them to swallow? Do we have a liquid formulation? Do they have easy access to a compounding facility that could potentially make this into a liquid? Those are also things to keep into mind. Finally, too, it is, as much as we all hate to do it, what will their formulary pay for with their insurance? Again, fortunately, we can usually get one good medication out of each category, but it can be more difficult to get some of the more second-line medications. So that's also something to keep in check. I don't know, that was 5, but hopefully that helped.
No, I think that fits. That's good. Okay, here's another one. With the multiple back order of stimulants going on this year, have you found it more helpful to change to a different stimulant or to try non-stimulant options?
Yes, I knew that question. Sorry, I knew that question was coming. So no, it's been very frustrating. One thing that we've found helpful is to really kind of enable and encourage patients and parents specifically to call around. The pharmacy stock has been so different, even around Austin, that rather than, number one, change a kid from a medication that's been working really well for them, I will first ask parents to kind of just call and check that it isn't available at another pharmacy that's nearby. That said, it can depend on what's available. There are some patients, like I said, I have switched them, for example, if they're on Adderall specifically. I will switch them over to Vyvanse if possible, or in some cases, immediate release formulations, as those have been easier to get. Again, I will talk to parents that this is a short-term measure, secondary to the shortage. Routinely, in terms of switching to a non-stimulant option, particularly if they've been having good results with a stimulant option, that's not something that I would recommend unless there really are no other options. And part of that reason is kind of like we talked about, there is a difference between how well stimulants work and how well non-stimulants work. So really kind of risking that you could see a drop in performance is probably, I think, less wise.
Dr. Veda, why is there a shortage?
So, interesting question. Initially, what was reported was that it was due to difficulty producing it due to the pandemic. However, as the pandemic has kind of gone on, people have gotten back to work. The new kind of hypothesis is it's because there's been such a jump in the diagnosis, and there's been more demand rather. So that supply hasn't been able to keep up. So that is what the latest news has been telling us. We unfortunately don't really have a good idea of when said shortage will improve, however.